Thank you, Beth. Good afternoon. Always the afternoon talk is mine. Just make sure, if have to keep it entertaining so people are not sleeping when they're listening to me. So first foremost, I think I'll start the STEMI talk, how we take care of a patient that presents with the STEMI when they come to us in the cath lab. So here is a 73-year-old male who presented with acute STEMI, and how this presentation was, he had a chest pain, and EMS was called, EKG this current day they do the EKG at home, then the ER patient presented to the ER, and he was given aspirin, heparin, low pressure, and this is where the EKG, if you see here, or ST elevation in the inferior lead. Right now what happens actually is that ambulance people actually activate the cath lab, so they will alert us as well as the ER. So our team will be waiting for the patient downstairs, and once we confirm it's a STEMI and we know this patient can go to the cath lab, the patient comes up. This is all to decrease the timing when this vessel will be opened. So when the patient presented, of course, you gave extra medication, which is an antiplatelet agent other than aspirin, which is a ticagrelor, was given in the ER, comes up to us, and this is what we find, which I'm going to show you, but his EDP was elevated at 35. He had both, this is the LAD, the anterior descending, he had disease in the mid LAD as well as the diagonal that you see there, and you see here the right coronary artery that is filling, which is giving us a hint that that vessel is occluded. So you're wondering what is going on, other than me telling the fellow that you don't know how to pan. And what was going on here, as you see that RCA, which is totally occluded here proximally, but more important, first injection, patient goes into VFib. And this is, you see that ST elevation and VFib, and this is when the first thing that you do is shock the patient, and your goal should be how quickly you want to open the artery and revascularize that artery. That is what was done. That one stent was placed, and the patient had the artery open, subsequently was stable, and was transferred to CCU. So when they go into CCU, this is where I think both the nurses from the lab as well as nurses in the CCU take care of this patient, where we done our part, that we have opened the artery. The subsequent management is continue antiplatelet agent, make sure the patient is on medical therapy for the heart disease, which could be a beta blocker, but more important, based on his LV function, whether he gets ACE inhibitor, or if he was not on a statin, he has to be on a statin. We did do a good job. How do we know that? See that STs have come down. This is what he was when he went to CCU. And this is the EKG, his ST is down, and blood pressure was stable at 100. If the blood pressure was low, this is the time we'll decide whether he will need an IABP or even probably an LV assist, which would be an impeller. Now, what happened to him subsequently after a few days, this is 48 hours later, that he had an episode of ventricular tachycardia when he was in CCU. So the question always came that he still has residual disease, as well as we want to make sure the stent we just did was okay. So he comes back to the cath lab, and of course, the stent that we did, you see that this is not normal. You see like there's a filling defect. So it could be two things. One, thrombus formation back in the artery that was that large, or that there was a lot of plaque that protruded through the stent back. So only way you'll know this is that you have to have some kind of imaging done, which I think the various imaging tools have been discussed this morning in 2 talks. So he had imaging done, and based on what we found, all we did was just do a balloon dilation, and this is how the artery looked. And this is what the imaging was, the optical coherence tomography, or OCT, that was done. If you see here, definitely showed that there was thrombus there. This is patient on aspirin. He had received heparin, and on ticagrelor still got that. And this is how what you see, OCT image. This is post-procedure. All the thrombus was gone. And Important thing that for interventionalists, we also have to make sure the stent is well opposed, which looks like it is well opposed. And now we are not sure what do we do with this LAD. I will go over the trials, which tells you if they come with the residual CAD, should you take care of that or leave them alone? But somebody who already presented with the ventricular tachycardia, which means that he's telling us that lesion is ischemic, that vessel was taken care. Just to tell you what has happened is with the incidence of MI versus the incidence is going down mainly because patients are getting good medical therapy, especially statin. And also very important is that patients are being taken care at an early time and mortality has gone down. Since in the past, the treatment for STEMI used to be thrombolytic therapy, but then since angioplasty has come into existence, everybody gets PCI for presentation of STEMI. And that's when the door to balloon time came into existence. This door used to be the door of the hospital, the ER. Right now, the door has moved to the patient's house. So if a patient makes a phone call and the EMS is by the patient's house, then they do an EKG. That is when it's transmitted to the on-call doctors, because they will pick the hospital that's the nearest and they will transmit the EKG to the on-call doctor. We say, yes, it is STEMI. Patient can come either to the emergency room of that hospital, or many hospitals will say bring the patient directly to the into the cath room, and that is how you decrease the door to balloon time. Goal used to be 90 minutes. So this is where we are. If you see that, the less than 90 minutes, if you have that, definitely the mortality of these patients went down. So if you see in the beginning, early part used to be 96 minutes in 2005, but in 2011 we went down to like 66 minutes. Why did this happen was the trial that was published in New England Journal, which actually showed that you need system in place. It is not just the PCR, but you need system in place, and various system in place is what I just mentioned, that you have the EMS making the decision, means doing an EKG, they're diagnosing, they're making the decision based on after discussion with the on-call doctor, and then you bypass the ER, bring the patient directly. Because of this, what you need to do is avoid pager system. They email most of the doctors who are involved and the cath lab staff. And also other thing that they've decided is in many hospitals, the staff, they are in-house, or all the doctors, even the interventional cardiologists could be in-house. So they put a system in place. By putting various system in place, they definitely what they did was the door to balloon time decreased. So if you see here 2010, door to balloon time of less than 90 minutes was achieved in almost 92% of the cases compared to less than 50% in 2005. Now the question comes, yes, so we are going, the door to balloon time has improved. Did we do anything good to these patients? Did the mortality change in these patients who underwent a primary PCI? But that is interesting if you see that door to balloon time has decreased, but